Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today I'm going to talk about anterior shoulder pain and restricted shoulder flexion and abduction caused by the pectoralis major muscles and the latissimus dorsi. And I probably throw in a few other things, but have you ever noticed some things that you don't really see very often will come to you during the week in clusters of patients with the same problem? This past week, I had 3 different patients where I had to treat the Pec Major for shoulder pain. And the week before that, it was all thumb issues. It was lots of thumb flexor issues. And it's just so strange how that will happen. Like, I don't treat a lot of thumb pain or restriction on a weekly basis. I mean, I see it occasionally, but I had like 2 or 3 people, like in one day, I was treating 3 different people's thumbs. But anyway, this past week, I have different patients, most of them older, who have had anterior shoulder pain. And one of them, her physical therapist still insists that she has a frozen shoulder. And she continues to improve by working on the lats and the pecs. I've worked through deltoids and rotator cuff and all that stuff, but she continues to improve, and the winning strategy this week that got her quite a bit more range of motion so that she could lift her arm up past the level of her eyes, because she was getting to like the level of her shoulder at first, and then a little higher. And then this time she was actually I think her hand was higher than her head at the end of the treatment after releasing the sternal head of her Pec Major. I worked on the clavicular head as well, but I think it was the sternal head because of the tight bands that I felt in there. And I had to get some good twitches like trigger point release. I have a different patient that I'm thinking of, though. He can't feel his right side because of a stroke he had several years back. But he has a hard time raising his arm as high as the other side, the affected side that he can't really feel. But he has a sense of the restriction. So I've, of course, worked on rotator cuff and deltoids. A lot of it didn't really test weak, but it was apparent to me from length testing that his lats and pecs were very likely the biggest inhibitor for shoulder flexion. So I've been dry needling his lats because they're just super ropey, tight. Electric stim was not cutting it. It wouldn't stay better. You could release the lats with the electric stim and it would look like it was better. And then when he would come back, it was back to not being good. So I started doing more dry needling of the lats. And then this week I had already seen that treating his Pec Major was improving his shoulder range of motion. So that was one thing that I was doing with just electric stim and just using the pointer device on the Pec Major. And so I saw that, he's coming back just as bad as it was before. So I switched over to dry needling on the lats. And this week I did the lats and I did dry needling of his Pec Major. And it was a huge improvement. Big. Like, I think back to as good as the other side. And he was really happy with how good it felt, that he didn't feel the pulling that he had before. He had really tight, ropey bands of muscle in his Pec Major. I think he's in his late 50s. And I don't usually dry needle the Pec Major, but on him it seemed apparent that it was going to have to happen. It needed to be done. And I warned him, you may get bruised. A Pec Major bruise is usually black. It looks worse than it is. Someone who can feel will still not feel it as a bruise. It'll just look really bad. It'll look like a black disc, and it doesn't necessarily have any pain when you press on it. It must be just super vascular with lots of little capillaries, because if you get even a drop of blood on the Pec Major after a motor point release, you're very likely going to see a bruise later. I think the blood pools right under the skin, so it looks like a bruise, but it's really just a black disc of dried blood under the skin, which is why it doesn't hurt. So, okay, so that guy, Pec Major for the win. And of course, I didn't see him yet for the follow-up, but I'm very confident that this time it's going to hold. My other guy, he's like 70. He likes to ski, and he's had a lot of problems on one shoulder, and we've worked through a lot of those problems, and much of it has been posture induced. It's an upper cross syndrome sort of impingement of the shoulder. So I'm working on postural stuff. I had already been working on his pecs. I worked on his lats, worked on rotator cuff deltoids. And he said the one last pain that he gets is when he plants a ski pole, he feels shoulder pain in the front of the shoulder. So for me, that's a dead giveaway, because when it's a deltoid issue, if it's a bicep, long head of the bicep issue, there's going to be pain on shoulder flexion, not shoulder extension. So planting the ski pole is shoulder extension. And what attaches on the front of the humerus? The lats, the Pec Major muscles, and the teres major. So I had already been working on teres major, and I had been doing work on his lats, but what I realized was that I needed to dry needle his lats. So I started to do that, and the pain is now gone, consistently gone. I've seen him a couple times since dry needling the lats, but this time I know he was still, he would feel a little bit of pain, like lying on the table, raise his arm over his head, he would feel an anterior shoulder pain still. And it was not terrible. It was just an ache. And I did length testing, and I said, okay, we're coming back to the Pec Major. And this time, because of my other guy that I dry needled, I said, okay, I'm going to feel and see if this guy has the same ropey bands in his Pec Major. And he did. He had these like hard, rigid, like fish bones of trigger points in his Pec Major. This not the clavicular head. I did treat the clavicular head with electric stim, but his sternal head had these crazy tight bands. So I dry needled his pec, and it fixed the problem. Like he felt really good. He felt better mobility and zero soreness or pain. And then I have another patient who, oh wow, I have two other patients. Okay, so then I have another patient that was, this is the one that was told that she has a frozen shoulder. And same thing. I did not dry needle her Pec Major, but treating the Pec Major made that better. No, there was another patient. She's a regular. I would see her like once a month for maintenance. Well, she has been painting in her home, and she's over 60. She's been painting the ceiling, and she needed to get in as soon as possible because she couldn't sleep from shoulder pain. She said, I don't know what I did. Like all she thought it was like her chair yoga, and nothing she was doing in chair yoga was using those shoulder muscles. So, because she was just doing sort of like abdomen exercises where you're like lifting the knee and crossing your elbow over to the knee. I said, what else have you been doing? She's, well, we've been painting the ceiling in the kitchen because they just did some remodeling. I said, yeah, okay, so your arm's been up over your head for a lot of work. And I think that's what really tipped this into excruciating pain. But I'll cut to the chase. She had stuff going on in the deltoid. She had stuff going on in infraspinatus. She had lat, like soreness. And the last bit, she a lot of it was better. And then she would raise her arm in front of her, and she said, I feel this expanding like tension and pain. And she touched the front of her forearm, not forearm, front of her deltoid area. And it was low enough that it was not a deltoid insertion area. It was not her bicep, and it was not the acromioclavicular or the glenohumeral area. It was like, several inches lower than you would expect for a deltoid or bicep pain. And it was not anything like an infraspinatus pain. So I treated her Pec Major, and then it was gone. The pain was gone. So I just had like all this sort of strange Pec Major anterior shoulder pain people. And what's interesting is that raising their arm just in front of them, just doing shoulder flexion, will cause anterior shoulder pain. And that's typically going to be a deltoid or an infraspinatus patient. Possibly, if the palm is up as like a speeds test, that could be like bicep tendon sort of anterior shoulder pain movement. But on all these people, it was lat and Pec Major. So I think it's totally weird. But if you're familiar with working with the upper cross syndrome, this is like in your wheelhouse. This is the stuff that you're working on a lot for shoulder pain, neck pain, all that sort of stuff. So don't forget the pecs and the lats. They're really, really important and can cause shoulder pain and definitely cause shoulder restriction on flexion and abduction. And remember these things for when you're working with athletes, because if you're only treating what hurts, you're missing half of what you can do for an athlete. Improving their mobility, improving their joint range of motion is also improving their stability and their strength. So if you're only looking for weak or only looking for pain, you're doing the bare minimum for an athlete. We need to think about all the things that will restrict, for instance, on a baseball pitcher, like all of the things that restrict their external rotation of the shoulder and their torso movement, and what else can you improve to increase their strength on throwing. So you're going to get into a lot of muscles that are not going to test weak and are not going to cause pain. You're going to work on triceps. You're going to work on deltoids for shoulder mobility, for external rotation of the shoulder. You're going to work on the pecs and the lats and the serratus anterior and the obliques. And of course, you're going to look at hips for someone who needs power. None of that is going to test necessarily weak or painful. So thinking functionally will lead you to better results than just looking at what's weak and what hurts. We're improving the mobility, we're improving movement, we're improving joint function. And that's giving people power, that's giving them strength. When you're working with runners, don't just work on their tight quads and their tight hamstrings or their tight low legs. Remember their psoas. The psoas is going to make them run faster. Of course, work on the glutes, glute medius, TFL, glute minimus, even if they're not testing that week, whatever you can do for an athlete that will relieve some of the muscle shortening that we all have is going to improve their performance. And it's something that mostly only athletes will appreciate. I don't recommend you try to optimize mobility and strength on every single patient you will not have the time to do that. You don't need to do it for the average person. They're just going to go and sit. But when you're working with athletes, you really need to think about their power, their mobility, their stability, and whatever you can do to improve their joint mobility, their joint range of motion is giving them an edge that others will not have, because most people are not able to find any kind of methodology that's going to reset short muscle. So, for when you're thinking about athletes, don't be hesitant to treat muscles that are not testing weak or causing pain. You'll start to understand the improvements of mobility that you're giving somebody when you think more functionally. So when you're thinking about a baseball pitcher and you're releasing their pec major, the sternal head and the clavicular head. Clavicular head's huge because it's a shoulder flexor, and that's pitching all day long, right? For a baseball pitcher, they're going into flexion every single time they're throwing. So, and then improving their external rotation, their shoulder external rotation, subscapularis, middle delt. I would treat all delts, the lats, the other rotator cuff muscles surprisingly can improve their external rotation. So don't be afraid to treat external rotators to improve their external rotation, because just having less tension there seems to help the subscapularis to release better. It's like reciprocal inhibition. Deltoids, tricep, long head of the tricep. That's going to improve their overhead reach. And like I said, Pec Major, the sternal head, the clavicular head, all of that's going to improve their ability to externally rotate their shoulder. The serratus anterior, when it gets stuck short, then it's also not only not stabilizing well, but it's protracting. Some of those fibers that protract the scapula are going to affect their pitching, their external rotation. And an optimized serratus anterior has a lot more power when they throw. So when you're working with an athlete, think about the movement, the function. What are they actually trying to do? What are the movements that they have to do? And how can you help any of the muscles that affect their joint mobility? So it's a shift in thinking to not focus entirely on pain and what's testing as weak, and recognizing the function of all of the muscles that make a joint function. And think about reciprocal inhibition. Think about how muscles can structurally affect the mobility of the joint, even though the action of that muscle is not in alignment with what mobility movement you're trying to improve. The middle scalene does not rotate the head, but a tight middle scalene will inhibit left-right rotation of your head. You'll see lots of things like that. Like I say, the middle head of the deltoids will inhibit overhead reach. It's not a shoulder flexor. It's not an external rotator. But when it's tight, it's structurally, mechanically restricting the mobility of the shoulder. So the more you do things, the more you're thinking about it, and the more you're working with people and treating muscles, thinking more about improving the mobility of the joint and not worrying so much about which ones are testing weak, you'll start to see how you can help athletes and dancers, gymnasts, runners, by improving everything that they need to be fast, strong, and stable. So I guess that's enough for today. Remember the pecs, remember the lats when you're dealing with anterior shoulder pain and when you're dealing with shoulder mobility, because it's a huge, huge thing when people have a pseudo frozen shoulder, and it's part of it is postural impingement, and sometimes it can just be a matter of lats and pecs that are restricting their overhead reach, especially with your older patients. So don't forget it. And I guess that's good. Take care, and I will talk to you soon.